Good morning. Today we are going to discuss pathophysiology of glaucoma under the headings definition, aqueous humor dynamics, nerve fiber layer, optic nerve head, retinal ganglionic cell death, idiopathogenesis of glaucoma under primary open angle glaucoma, secondary open angle glaucoma, and angle closure glaucoma. What is the definition of glaucoma? Glaucoma is an optic neuropathy which is characterized by a progressive degeneration of retinal ganglionic cells and axons leading to a characteristic pattern of optic nerve head cupping and visual field loss. Intraocular pressure is a major risk factor. It is not required for the diagnosis as glaucoma can occur with normal intraocular pressure, which is known as normal tension glaucoma. So for the glaucoma to occur, we required retinal ganglionic cell degeneration, axon degeneration, optic nerve head cupping, and intraocular pressure changes. Aqueous humor dynamics. Understanding the trabecular outflow which occurs from trabecular meshwork via uveo meshwork, corneoscleral meshwork, juxtacanalicular meshwork to Schlimm's canal to collector channels via direct system or indirect systems to episcleral veins. Uveous scleral flow from ciliary body to suprachoroidal space to ciliary body venous circulation to choroid sclera and orbital tissue. Nerve fiber layer. Nerve fiber layer consists of unmyelinated axons of the ganglionic cells which converge at the optic nerve head, passes through lamina cribrosa and become ensheathed by myelin posterior to lamina. The nerve fiber layer vary in their thickness from 0.5 to 2 micrometer. The cytoplasm of the axons contain microtubules, fine fibrils, mitochondria and occasional vesicles. This is our ganglionic cells. This is our retinal nerve fiber layers which are unmyelinated before lamina cribrosa. After passing it, they are myelinated in nature. So the arrangement of nerve fibers in retina are in the form of 5 fibers which are superior arcuate fibers, superior radiating fibers, inferior arcuate fibers and papillomacular bundles. The arrangement of nerve fibers differs from retina to the optic nerve head. The fibers which are most superficial in the optic nerve head are the most peripheral in the retina. The fibers which are more central in the retina are the more deeper in the optic nerve head. So optic nerve head anatomy. The optic nerve head or the optic disc is the anterior part of the optic nerve where the axons from retinal ganglionic cells converge and exits the eye. The axons are supported by glial cells and vascular tissue and are surrounded by meningeal layers. So the optic nerve head is divided into 4 parts: superficial nerve fiber layer, prelaminar region, laminar region and retrolaminar region. The most important for the pathophysiology of glaucoma is the laminar region, which is also known as lamina cribrosa, which provides a main structural support for the optic nerve as it exits the eye. It consists of a reticulated network of connective tissue beams that are composed primarily of collagen, extracellular matrix components including elastin, laminin, and fibronectins. The lamina beams also contains the capillaries that nourishes this critical region. On doing the scanning electron microscopy of the normal laminar cribrosa, it discloses the superior and the inferior portion have larger pores and few laminae beams, making them more susceptible to glaucomatous changes compared to the nasal and the temporal one, which are structurally more denser and more resistive. This difference explains the greater susceptibility to damage inferior and the superior region of the optic nerve. Understanding the basic blood supply of optic nerve head. Optic nerve head is divided into 4 layers and the 4 layers are supplied in different ways. The superficial nerve fiber layers are supplied by the radial peripapillary capillaries, which are direct branches from the central retinal artery. The prelaminar regions are supplied by the peripapillary choroidal vessels, which are branches from circle of Zinhaler. The lamina cribrosa are supplied from the circle of Zinhaler. The retrolaminar regions is supplied from short posterior ciliary artery along with the plial vessels, which are branches from the central retinal artery. So the optic disc is the visible portion. This is the visible portion of the optic nerve head where ganglion cells exit the eye to form the optic nerve. The cup is the central depression within the optic disc where no nerve fibers are present. The CDR is the clinical measure used to describe the size of the optic cup relative to the optic disc. Neuroretinal rim is the area between the outer margin of the cup and the edge of the disc containing the axons and the retinal ganglionic cells. A healthy rim is uniformly pink in color and follows the ISNT rule, which is inferior, superior, nasal and temporal. The most thickest rim is in the inferior area and the most thin rim comparing or is in the temporal region. So what leads to glaucoma? So glaucoma is mainly caused by the retinal ganglionic cell deaths. Retinal ganglionic cell death is initiated when some pathological events block the transport of growth factors neurotropins from brain to the retinal ganglionic cells. Normally, when there is retrograde transport of the neurotransmitters, it leads to the nourishment of retinal ganglionic cells. Whenever there will be blockage in this retrograde transport, it will lead to the death of retinal ganglionic cells. The blockage of these neurotropins initiate a damaging cascade and the cells is unable to maintain its normal function. It loses its ability to maintain the normal function undergoing apoptosis and also triggers apoptosis of adjacent cells. And it associated with the death of nerve fiber layer. So retinal ganglionic cell deaths causes. It can be due to primary insult or it can be due to secondary insult. What is primary insult? Primary insult is the direct trauma to the cells which can be due to the elevated intraocular pressure or the ischemia on optic nerve structures or function. What is secondary insult? Secondary insult are the neurodegeneratives or inflammatory process which occur following an initial mechanical or vascular damage from the primary insults. The primary insults are due to raised intraocular pressure, which is mechanical theory, and pressure independent factor, which is the vascular theory. Secondary insults are glutamate toxins, oxygen free radicals and nitric oxides. So whenever there will be primary event which can be increased intraocular pressure or reduced ocular flow and or there is reduced ocular perfusion pressure, it will stimulate the secondary events which will lead to retinal ganglionic cell deaths and will lead to glaucoma. So the retinal ganglionic cell deaths are responsible for intraocular pressure and the vascular insufficiency. Both the mechanisms are interconnected via glutamate receptor upregulation, oxidative stress, nitric oxide synthesis 2 activation, TNF alpha upregulations, extracellular matrix changes. Due to intraocular pressure, there is growth factor deprivation, which is the neurotropin factors, and due to vascular insufficiency, there is upregulation of endothelins, which also lead to RGC death. So, etiological factors: primary insult, raised intraocular pressure. It proposed that elevated intraocular pressure leads to structural deformation of the lamina cribrosa, resulting in optic nerve damage. The key mechanism is increased intraocular pressure, which leads to posterior bowing and compression of lamina cribrosa and distortion of laminar pores, which results in axonal compression, disruption of axonal flow and ischemia, and ultimately leading to RGC apoptosis. So the structural changes in lamina cribrosa that occurs in glaucoma are posterior displacement of lamina, thinning of lamina, remodeling of extracellular matrix and enlargements of pores. So whenever there will be intraocular pressure, it will lead to the posterior bowing, its thinning, remodeling in this extracellular matrix and the enlargements of the pores. Posterior displacements is important because it helps to relate it with the glaucoma severity. The thinning of lamina leads to weakening of structural supports due to loss of connective tissue integrity. The remodeling of extracellular matrix leads to increased collagen cross-linking and elastosis, which leads to stiffening and permanent deformation. Enlargement of pores causes less support to the axon, which facilitates axonal loss. So here is in this diagram we can see it is the normal lamina cribrosa, which is a flat contour. In this diagram, which is pathological, we can see there is marked posterior displacement of lamina cribrosa. There is thinning or loss of the laminar structures. It has decreased axonal loss and laminous remodeling, and the connective tissue appears more collapsed and compacted. The deepened laminar cup is a hallmark of advanced glaucomatous cupping. So there are two types of pressure in the eye. One is role of translaminar pressure and the other is role of translaminar pressure gradient. So what is translaminar pressure? Translaminar pressure is the intraocular pressure minus cerebrospinal fluid pressure. It explains the occurrence of the normal tension glaucoma, which results due to low cerebrospinal fluid pressure and the increased intraocular pressure. And high tension glaucoma, which is due to increased intraocular pressure and can be due to normal cerebrospinal fluid pressure. The role of translaminar pressure gradient, which is equal to intraocular pressure minus cerebrospinal fluid pressure upon thickness of lamina cribrosa in micrometers. It is the rate of change of pressure that occurs across the thickness of the lamina cribrosa. It represents how steeply the pressure changes across the thin structure of lamina cribrosa and is directly related to laminar deformation and axon damage. High translaminar pressure gradient associated with axonal stress, disruption of axonal flow and optic nerve cupping. The pressure independent factor vascular theory. So there are certain factors which have certain mechanisms and its clinical relevance. First is vascular dysfunction. Its mechanism is whenever there is impaired autoregulation of optic nerve head blood flow, it leads to transient ischemia. Transient ischemia leads to trigger of systemic and local vascular instability, which increases susceptibility of optic nerve to minor intraocular pressure fluctuations, which is more common in normal tension glaucoma. Nocturnal hypotension. Excessive drop in the systemic blood pressure at night reduces the ocular perfusion flow. This ocular perfusion pressure when decreases leads to worsening of the ischemia during the sleep to the optic nerve, which contributes to the glaucomatous damage despite normal intraocular pressure. Whenever there will be hypotension, there will be reduce of the ocular perfusion pressure, which will reduce the retinal flow and will cause RGC degeneration. Low ocular perfusion pressures. Low ocular perfusion pressure impaired blood supply and is associated with increased risk of glaucoma and normal tension glaucoma. Vasospasm. Transient vasospasm of blood vessels, which are common in Raynaud's phenomena and migraine. Whenever there will be transient vasoconstriction in the blood vessels, then there will be reperfusion to the tissue. Sometimes the sudden reperfusion causes reperfusion injury to the surrounding structures, which causes the oxidative stress in the area and will stimulate the oxidative pathway and will cause the injury. So reduced optic nerve head perfusion and oxygen delivery is the risk factor for NTG. Endothelial dysfunction. Abnormal nitric oxide and endothelin 1 leads to vascular tone and autoregulation, which contribute to unstable ocular blood flow and optic nerve ischemia. Whenever in patients such as diabetes and hypertension, the endothelin factors which is present on the blood vessels, it upregulates and causes vascular disruption and impaired autoregulation, which ultimately lead to decreased retinal flow and RGC death. Blood viscosity and hypercoagulability. Due to increased blood viscosity and platelet aggregation, it impairs the microvascular flow in the structures. Due to compromised microvascular flow, it will affect the perfusion of the optic nerve capillaries. Sleep apnea syndrome, in which it occurs intermittent hypoxia and hypotension during the apnea episodes. This intermittent hypoxia and hypotension episodes will increase the risk of ischemia to the optic nerve, which will increase the risk for normal tension glaucoma and its progression. So vascular dysfunctions which occurs in slim, hypotension, cold hand people, cold feet people, athletes have a tendency of Lammer syndrome, which leads to disrupt autoregulation and causes normal tension glaucoma, because in these conditions it leads to peripheral vasoconstrictions of the vessels, which ultimately leads to optic reperfusion injury and the optic nerve head injury. In patients such as obesity, hypertension, dyslipidemia, diabetes, smoking, they have an increased risk of arteriosclerosis, which ultimately increase the endothelin factors and causes the decreased ocular perfusion flow and the ocular hypertension. Secondary insults are due to neuronal degeneration by toxic factors such as glutamate, which is excitatory toxin, oxygen free radical, nitric oxide, which are released when RGC undergo death due to primary insults. Glutamate related toxicity. Whenever there will be hypoxemic conditions, it will release glutamate with the help of NMDA receptors, And these elevated glutamates will cause neuronal toxicity because it will increase the calcium influx in the cells. The increased calcium will activate the secondary messenger activations which are in progress with the apoptosis and will cause the cell deaths. So whenever you are giving normally you give calcium channel blockers, it causes neuroprotection because it is preventing the secondary messenger activation and it improves blood flow. But whenever there is reduced systemic blood pressure, it will decrease the blood flow and it will worsen the ischemia. So calcium channel blockers should be avoided in patients of glaucoma. Nitric oxide and cellular destruction. Due to exposure to cytokinins and pressure, it will lead to excessive nitric oxide production, which will diffuse inside the cells and produce free radical and will cause cellular destructions. Glaucoma. So we know there are two types of glaucoma, primary open angle glaucoma and primary angle closure glaucoma. Primary open angle glaucoma, the glaucoma can occur due to decreased outflow facility or the normal outflow facility, and primary angle closure glaucoma can occur due to pupillary block or non-pupillary block mechanisms. So whenever there will be aqueous humor drainage resistance, there will be increased intraocular pressure slowly and there will be accumulation of aqueous in the anterior chamber and this leads to open angle glaucoma. Whenever there is obstruction of aqueous humor drainage pathways, it increases intraocular pressure rapidly, causing accumulation of aqueous in anterior and the posterior chamber and leads to angle closure glaucoma. So to understand the dynamics of intraocular pressure in primary open angle glaucoma, we have to understand the decreased outflow facility mechanism and the normal outflow facility mechanism. In decreased outflow facility, we have impaired drainage, and in normal outflow facility, we have a normal drainage pathway. So factors affecting outflow facility in glaucoma. It can be trabecular meshwork cell dysfunction, extracellular matrix remodeling, oxidative stress, aging, myelocynin mutation, TGF-beta overexpression, JCT resistance, Schlimm's canal dysfunction, or increased episcleral venous pressure. So understanding a pathophysiological features, its mechanism and its impact on outflow and intraocular pressure. Where the juxtacanalicular tissue resistance. The JCT and the inner wall of Schlimm's canal are major resistance sites. Whenever there is extracellular matrix accumulation, it causes outflow resistance and it decreases outflow and leads to intraocular pressure elevation. Trabecular meshwork cells dysfunction. The normal trabecular meshwork cells has some endothelial cells which has phagocytosis activity. Whenever there will be the less of TM cells, then there will be reduced phagocytosis activities, there will be increased accumulation of debris and cytoskeletal abnormalities, which will lead to increased aqueous resistance and impair self-cleaning capacity of trabecular meshwork. Extracellular matrix remodeling. Whenever there will be increased deposition of fibronectin, laminin, collagen, folds, it will lead to reduced MMP activity and enhanced TIMP expressions. This will alter TM permeability and stiffness tissue and reduce the outflow resistance. TGF-B2 overexpression. Whenever there is elevated levels of TGF-beta2, it stimulates ECM synthesis which suppresses its degradation and induces TM fibrosis, which will lead to structural changes in the TM and will decrease its outflow. Myocilin mutation. The MYOC gene mutation produces abnormal proteins which accumulates in trabecular meshwork and leads to ER stress and apoptosis, which reduce the TM cell number function and increase its resistance to flow. Oxidative stress or aging. Whenever there is free radical generations due to damage to trabecular meshwork, mitochondria and DNA, cellular senescence and death occurs, which is more prominent with age and lead to progressive TM dysfunction and reduced outflow facility. Reduced Schlimm's canal function. Whenever there is collapsing or narrowing of the Schlimm's canal, it alters its shear stress and endothelial dysfunction, which impairs its transendothelial flow into episcleral veins. Increase episcleral venous pressure. Mild elevation in episcleral venous pressure can impair aqueous drainage despite normal trabecular meshwork. Back pressure reduce outflow facility. So whenever there will be episcleral venous pressure increase, the outflow facility from the trabecular meshwork is decreased. That's why when we do sheets asana in yoga, all our venous blood pooling occurs over our brain side, which causes increase in the episcleral venous pressure and causes the increased intraocular pressure. IOP related structural effects. Elevated intraocular pressure stresses lamina cribrosa, which leads to axonal decompression, disrupted axonal plasma flow, and RGC apoptosis, which leads to progressive optic nerve head cupping and visual field loss. Causes of normal outflow facility dysfunction, which includes genetic predisposition, nocturnal hypertension, optic nerve head structural susceptibility, excitotoxicity, oxidative stress, mitochondrial dysfunction, vascular dysfunction, and autoimmune mechanisms. So first is vascular dysfunction. Whenever there will be abnormal autoregulation of optic nerve head perfusion, it will lead to transient ischemia despite normal IOP. This chronic ischemia leads to RGC death and optic nerve head cupping. Nocturnal hypotension. Whenever the blood pressure drops during sleep, it leads to reduced ocular perfusion pressure. The repeated decrease in the ocular perfusion pressure leads to ischemic changes in the RGC axon and its death. Optic nerve head susceptibility. Thin lamina cribrosa or reduced connective tissue support may predispose nerve to damage at normal intraocular pressure. Whenever there will be increase in intraocular pressure, it will lead to mechanical strains on the axons and disturb the axonal flow. Mitochondrial dysfunction. Impaired energy metabolism in RGCs lead to increased oxidative stress and reduced cellular repair and promotes RGC apoptosis independent of intraocular pressure levels. Oxidative stress. Reduced oxygen species. Reactive oxygen species accumulate in optic nerve head and retina and which does not neutralize efficiency leads to damage of cellular proteins and DNAs and lead to RGC loss. Excitotoxicity, mainly glutamate. Excessive glutamate activates NMDA receptors which causes influx of the calcium will lead to secondary messenger activation and neurotoxicity in the RGC which leads to its apoptosis and progressive visual field loss. Autoimmune mechanisms. The axons of the retinal ganglion cells have heat shock proteins. Sometimes autoantibodies are produced against these heat shock proteins and lead to their death, which leads to inflammatory response in the body. Genetic predisposition. Gene mutations such as OPTN, TBK1, OPA1 influences mitochondrial function and optic nerve integrity. Increased damage to glaucomatous despite normal IOP. Causes of secondary open-angle glaucoma, which include pseudo-exfoliate glaucoma, pigmentary glaucoma, steroid-induced glaucoma, uveitic inflammatory glaucoma, traumatic glaucoma, lens-induced glaucoma, neovascular glaucoma, tumor-associated glaucoma, ghost cell glaucoma, and post-surgical glaucoma. So, pseudo-exfoliate glaucoma. PXG. There is deposition of pseudo-exfoliative material in trabecular meshwork which obstruct aqueous outflow. Trabecular meshwork dysfunction also contribute. The risk factors for this are systemic vascular diseases such as hypertension, cardiovascular diseases, genetic predispositions of LOXL1 gene variants, unilateral or bilateral PKF material on lens angles or zonules. Here we can see this the yellow deposits of fibrin materials in ciliary body, zonule, lens, iris, in the anterior chamber, cornea and the trabecular mesh. The collections block the outflow of the aqueous from the anterior chamber to the flow. Pigmentary glaucoma. There is liberation of pigment granules from posterior iris pigment epithelium due to iridozonular friction. There is deposition of trabecular meshwork causing blockage, which is common in young myopes male 20 to 40 years, deep anterior chamber and vigorous physical activity. Whenever there will be rubbing between the lens and the iris, pigments will be released and this will cause the blockage along the trabecular meshwork. Steroid-induced glaucoma. Glucocorticoid increase extracellular matrix deposition in trabecular meshwork, reduce phagocytic activities, and elevate outflow resistance. It occurs during long duration or high potency steroid exposures. So, to understand the mechanism of glucocorticoid steroid induced glaucoma, we should know there are two receptors in our eye for glucocorticoids, which is GR beta and GRF alpha. So GRF alpha binds with the glucocorticosteroids and stimulate the proteoglycan degenerations, and GR beta prevents the binding of GR alpha to the steroids, and this goes hand in hand. Whenever there is prolonged GC therapy, it causes more stimulation of GR alpha receptor, which causes more degradation of the extracellular matrix and its accumulation. So the GR beta upon GR alpha ratio reduces, which causes pathological damage to trabecular meshwork, and it creates aqueous humor outflow resistance, leading to intraocular pressure and damage to optic nerve head. Uveitic and inflammatory glaucoma. Inflammatory cells, protein debris clog trabecular meshworks. Cytokines induce structural damage. Steroid may exacerbate it. Risk factors are chronic or recurrent uveitis, posterior synechiae, pupillary block, peripheral anterior synechiae. Whenever there is oxidative stress, cell damage leading to increased lipid, protein expression increment or nitrate, these all increases the inflammatory mediators, which causes RGC apoptosis. These inflammatory mediators also activate the receptors and causes hyperactivation of calcium ATPase and increase the influx of the calcium, which ultimately leads to RGC death. It also dysregulates the sodium potassium ATPase pump, which are responsible for aqueous humor synthesis, and it disrupt the formation of aqueous humor. These protein expressions damages the aqueous humor dynamics, and ultimately these all combinedly leads to uveitic glaucoma. Traumatic glaucoma. Whenever there is blunt trauma, there leads to angle recession and TM damage or ghost cell glaucoma, RBC remnants, and hemosiderosis and angle fibrosis. So the risk factors are blunt or penetrating ocular trauma, angle recession more than 180-degree, hyphema or PAS formation. Lens-induced glaucoma, phacolytic. High molecular weight lens proteins leak through intact capsule in hypermature cataract and obstruct the trabecular meshwork. Risk factors are hypermature Morganian cataract, leakage of lens proteins in anterior chamber. Neovascular glaucoma or open angle phase. Vascular endothelial growth factor mediated neovascularization of angle structures lead to fibrovascularization and blocks the TM. The risk factors are PDR, CRVO, ocular ischemic syndrome, RD. So whenever there will be CRVO, it will lead to hypoxia and ischemia, which will ultimately increase the vascular endothelial growth factors, which will cause neovascularization leading to neovascular glaucoma. The concentration of vascular endothelial growth factors is more in anterior segment compared to the posterior segment. Intraocular tumor associated glaucoma. Tumor cell invades or compressed trabecular meshwork, seeding of tumor in angle or elevated episcleral venous pressure. Which risk factors are melanoma, retinoblastoma, lymphoma, metastasis, angle closure by mass effect. Ghost cell glaucoma. The degenerated red blood cells, ghosts, migrates from vitreous into anterior chambers post hemorrhage and obstruct the trabecular meshwork. Long-standing vitreous hemorrhage secondary to trauma, diabetes, retinal vascular occlusion. Glaucoma following vitreoretinal surgery, example in silicone oil. The emulsified silicone oil or inflammatory debris block the trabecular meshwork. The scleral bulking may raise episcleral venous pressure. So the risk factors are silicone oil overfill. Angle closure glaucoma mechanisms occur in two forms. One is pupillary block, lens induced. The other is non-pupillary block, which is anatomical considerations of plateau iris configuration, plateau iris syndrome, thick peripheral iris roll, anterior rotation of ciliary body, choroidal effusion, and iris anterior insertion. So the risk factor for angle closure glaucoma includes positive family history, shallow anterior chamber, short axial length, thick crystalline lens, older age, female gender, East Asian ethnicity. So the pathogenesis. Whenever there will be relative pupillary block, it will cause resistance to aqueous flow at lens iris interface. This will increase the pressure gradient. Posterior chamber pressure exceeds the anterior chamber pressure, which will lead to iris bombae formation. The peripheral iris will bow forward due to pressure. This will cause angle obstruction. Iris blocks the trabecular meshwork. Outflow is blocked and it will lead to increase in the intraocular pressure, and on continuous increase in the intraocular pressure it will lead to formation of peripheral anterior synechia and permanent angle closure. Angle closure glaucoma without pupillary block are anatomical considerations. First is plateau iris configuration. Anteriorly positioned ciliary process push the peripheral iris forward despite a deep central anterior chamber. The angle appears narrow, persistent angle closure risk increases. So in plateau iris configuration, we have a normal central anterior chamber depth with shorter root of iris and a planar iris configuration and the anteriorly placed ciliary body. Plateau iris syndrome. After laser iridotomy, release pupillary block, but angle remains narrow due to anterior ciliary body configuration. Continued oppositional angle closure despite patent iridotomy. So we have released the angle block which was at the iris lens interference, but due to the anatomical consideration of the iris, the angle still appears narrow. Thick iris Thick peripheral iris rule. The excessive iris tissue in the periphery crowds the angle, common in youngers. Mechanical crowding causes angle narrowing, particularly in dim light. The normal iris thickness at iris roots is 200, at mid iris is 400, and pupil is 500 micrometers. But in this we can see the iris thickness has increased to 500, in the mid periphery to approximately 750. Anterior rotation of ciliary body. Example in nanophthalmos. In small eye, thick sclera compromises uveal tissue, anterior rotation of ciliary body and shallow chambers. Persistent angle crowding and closure risk even post-iridotomy. So in nanophthalmos, we can see the anterior insertion of the iris. This white one is the ciliary body. Choroidal effusion or expansion. Idiopathic or drug-induced swelling of choroid causes forward displacement of lens iris diaphragm, which causes sudden angle closure with IOP elevation and shallow anterior chamber. So whenever there will be any choroidal effusion, it will cause shallow anterior chamber. Drugs which are anti-epileptic such as topiramate causes this. Iris anterior insertion. Developmental anomaly whereas iris inserts anterior to normal position on trabecular meshwork or shawl baseline causes congenital angle crowding, higher risk of closure. The anterior rotation of the ciliary body. Malignant glaucoma pathology. So whenever there will be initial triggers such as ocular surgery, laser, spontaneous event initiates the process which causes disruption in the aqueous flow. Aqueous dynamics are disrupted, which leads to aqueous misdirection into the posteriorly into the vitreous. Here the aqueous become trapped in vitreous due to intact hyaloid. The vitreous hydrates, increasing posterior segmental pressure and causes lens iris diaphragm forward displacement, which causes shallow anterior chamber uniformly, and the angle flows despite patent iridotomy and due to continuous increase in intraocular pressure. This cycle is continuous and exacerbating the conditions. Thank you.